Hello everyone and welcome to tonight's webinar. My name's Emma Helian from Murray PHN and tonight we're going to be talking about asthma in spring. So I'll just start by acknowledging that we're all sitting on traditional lands today and acknowledging the traditional owners. In my case that's the Dja Dja Wurrung Nation. We pay our respect to elders past, present and emerging and extend that respect to all Aboriginal and Torres Strait Islander people. So I'll now hand over to Marg Gordon from the National Asthma Council to talk about asthma in spring. Over to you, Marg.
Thank you so much. Thank you for coming to listen to Asthma in Spring, Allergies and Thunderstorms. My name's Marg Gordon and I work for National Asthma Council Australia. I am the program manager for the Health Professional Education program there, which is called Asthma Best Practice Program. And I'm a nurse asthma educator, and I usually would be working in one of the general practices here near me in Melbourne, but that's currently not happening because of COVID. So I'll be going through my presentation tonight, and as Emma said, we'll have our questions at the end. So please keep them all ready for us to answer together. Alrighty, so these are our learning objectives for tonight. So we're just going to be looking at allergic rhinitis and asthma and making sure that you understand the treatment guidelines for allergic rhinitis, because there's a strong link between allergic rhinitis and asthma. And then having a good chat about thunderstorm asthma and the guidelines for management. And of course, always covering written asthma action plans and asthma first aid in relation to thunderstorm season, which is now springtime, and we've had a wild and blustery day here in Melbourne today, and you may have had where you are as well. A typical spring day. Started off sunny and warm, ended up now dull and cloudy, sprinkles of rain, windy, dusty. So good time to be talking. This slide just talks about the handbook. This is the, oh, I've done that again, I beg your pardon. I'm just going to get that little thing out of the way. The asthma handbook, which allows us to, which is free and available to everyone online. So this is the website, www.asthmahandbook.org.au. And if you go into the handbook, it's got all the guidelines for management there. You can see the tabs across the top: diagnosis, management, acute asthma, clinical issues, population prevention, and it's got a very good search function there. But if you're looking for thunderstorm asthma, it's under that clinical issues tab. So that's where you'd be looking to find information on tonight. Now, just excuse me, I need to move this little controller so I can move my slides, and I know that I'm messing you around a little bit. I beg your pardon. All right, so allergic rhinitis, the facts. About 15% of Australians have allergic rhinitis, and if you think about that, that's pretty high. We've got about 11% of the population that have asthma, so even more people have allergic rhinitis, or hay fever as it's known in the community. It's often underdiagnosed, undertreated, or suboptimally self-treated. So there's a lot of medications available over the counter, and they may not be the best ones that people are thinking about using. It's common really in any age. I know little small kids that have got allergic rhinitis, and certainly older, but the data tells us it's common between those years, 15 and 54. And often people are allergic to multiple things, so it can be really difficult for them to try and work out what it is that's causing it, and it tends to be that we'll call it seasonal or non-seasonal. I like to sort of explain what we mean about this United Airways disease, and you would understand that asthma is an inflammatory condition. It's when asthma is triggered, there's inflammation in those small airways of the lungs, and that causes thickening, reddening and inflammation of the lining of those small airways, and creates mucus and narrows the airways down, and that's asthma. And allergic rhinitis is that very similar inflammatory process in the epithelial lining of the upper airways. So that's the nose, the back of the throat and the sinuses is what we call the upper airway, and the lower airway is the the trachea and the lungs and the airways in the lungs. So this United Airways disease is talking about inflammation of both of those areas, or one at a time, or sometimes both together. So quite a high percentage there of people with asthma have allergic rhinitis, and they may not think about their hay fever that much, but they certainly do have it. And 20 to 30% of those with allergic rhinitis have asthma. So it's really important when we're thinking about that we treat both conditions. Allergic rhinitis is an independent risk factor for asthma in children and adults. So the presence of both conditions often is associated with poorer asthma control, because we need to be treating both areas of inflammation, as I've talked about. So when we're assessing for allergic rhinitis, the symptoms can be quite common. Those itchy, watery eyes, runny nose, sneezing, that constant throat clearing from the postnasal drip that can occur, cough, which can happen from the same thing, mucus or watery fluid running down the back of the throat, frequent sore throat, so a dry, itchy, sore throat, might be snoring or mouth breathing. But I think when we want to think about these symptoms, this is why I mentioned that it's often suboptimally treated, because people will just put up with this. They know they've got a bit of it. They think, oh, it's nothing too bad, I won't bother, you know, but it's important to treat it, particularly if you've got asthma as well. We need to sort out the frequency of those symptoms. So when we're assessing and asking people about allergic rhinitis, we say, you know, is it seasonal? Is it perennial? What we mean by that is seasonal is generally associated with certain triggers. So springtime seasonal allergic rhinitis is often associated with grass pollens, particularly ryegrass pollens, but it can be weeds, seeds, dusts, other flowers that are occurring now. Perennial symptoms are often not associated with seasons, so they're things that are around all the time, and examples of that would be pet dander, dust mite allergies, for example, molds, airborne molds, those types of things. You can get those people that will suffer occupational allergic rhinitis as well, and that's more likely to be triggers such as chemicals or strong smells or fumes, irritants, those types of things. We assess the impacts of these symptoms. So is it affecting people day to day? Are the symptoms mild? Can they manage? Or are they more severe and we need to be really treating that? Symptoms that affect people daily certainly require treating. Symptoms that affect sleep or symptoms that trigger asthma, these are the real times that we need to be treating. Talked a little bit about the triggers there, so try and ask people about their triggers. Do they know what they are? Are they able to identify them in any way? When does it start? When does it end? Those types of questions. We would do a physical assessment as part of our assessment for hay fever, so looking at the airways, looking at those upper airways, at the turbinates, looking for inflammatory conditions, looking for that transverse nasal crease. This is the diagram here, that constant wiping of the nose, and they get this little crease here in the nose. A reduced nasal airflow, mouth breathing. Often people will have those dark circles under their eyes. That's part of the sinus congestion and sinus pain. So looking for those types of things. We'd be asking about those coexistent conditions that I've talked about, the other allergic conditions that are really relevant. Asthma and eczema are the main two. So all of this information is in the handbook there. That's the link, just so that you know, under clinical issues as well, there's a section on allergic rhinitis. So we'd be looking to diagnose the condition if we possibly can, and this would be for the more moderate severe. In mild conditions, we may not worry about doing allergy testings, we might just treat and look after the symptoms. But in those that have got more severe condition, we would be doing some investigations. And skin prick test, allergy skin prick testing is sort of the gold standard of tests because it can be so very specific. So you'd perhaps be familiar, and this picture sort of shows that it's allergen is placed onto the skin, and a little skin scratch is there, and then wait 10-15 minutes and measure the reaction there, and that can be very specific. People do need to go to an allergy specialist to access skin prick testing generally. We can do serum-specific IgE tests or RAST testing, as you'd know them by, but once again, if they're going to be helpful to us, they need to be quite specific. So those tests are available, and that might be something that people can access more simply, a blood test, but we need to make sure that they're fairly specific if we're going to do them. We need to remember that positive results don't necessarily prove that the allergens are causing the symptoms. It's another link in the puzzle, but we just need to remember that. There are a variety of tests out there that are not particularly useful. Food allergies are not really strongly linked to allergic rhinitis symptoms as such, so the food allergies tend to have more gut-related symptoms, so that might not be terribly helpful. But in people who've got a strong feeling that that's the case, then they would definitely benefit from food allergy testing. But general FBE and total IgE is often not of much clinical use. It tells us there's inflammation there, but it doesn't tell us a lot else. And then some of the more or less proven testing methods, such as kinesiology, reflexology, hair analysis, those types of things, they're often really expensive for folk, but don't tend to give us a lot of really useful information. So talking about allergic rhinitis treatment, and I'm sure many of you like me who do get some rhinitis, you go to the pharmacy and there's a whole aisle of different treatments, and we need to be really aware of that they're available over the counter. And it's not always the best way for people to be choosing what they need. They really need to be speaking to the pharmacist or their GP or their asthma educator or their allergy specialist about what's best for them. And that is dependent on exactly that assessment that I've been talking about, how frequent their symptoms are and how severe their symptoms are. But the best sort of treatments now are the intranasal corticosteroid sprays. They're available on script and off script. A lot of them are now non-scripted, which is great. And they actually treat the inflammation. The antihistamine nasal sprays reduce the symptoms, but don't necessarily treat an inflammation. And combination nasal sprays are where you've got the corticosteroid component and the antihistamine in the one device. And they can be really useful for people. They are scripted medications in Australia, but they can work very, very well. We've got rapid-acting oral antihistamines, always recommend non-drowsy ones for people. And we've got the 24-hour acting, you know, I'm not going to go into all the different ones of those. I'm sure you're familiar with lots of them, but they are available and they can be used in combination with the nasal sprays. People may need both, depending what symptoms they get, but, you know, they can be very helpful as well. We've got saline rinses, so we also have saline nasal sprays, but we have saline sinus rinse. So it's not a terribly pleasant procedure to self-perform, but it can be really beneficial, and it literally does just give the sinuses a salty wash and help people to feel as though they can clear their sinuses out a little bit. So that can be very helpful. On the National Asthma Council website, there's a library of how-to videos. They are for asthma devices, but there's also nasal sprays and sinus rinse videos there as well. So if you want to familiarise yourself so that you're teaching people the correct ways to use the sprays, because with all medications, inhaled asthma medications and nasal sprays, there's a right and wrong way to actually use that device. So please pop on the NAC website there and have a look at those videos and make sure that you're showing people the correct way to use the devices so that they get the best benefit out of them. Another important part of that is so that we are reducing the side effects for people. So all medications have side effects. Nasal sprays are no different. For the corticosteroid nasal sprays, the common side effects are a very dry nose or even blood noses. So just making sure people are using them correctly can minimise those side effects for folk. Other treatment choices can be allergen avoidance. That can be very difficult for people if they've got airborne allergens. So a hot, blustery day like today, there's dust and pollen in the air, and that's very difficult to avoid. But it can be something that we can certainly talk about. There's allergen desensitisation available, once again through an allergy specialist. but these are sublingual or subcutaneous immunotherapy, and that can really help change people's lives. These are the only treatments that actually modify the allergic immune response for folk, so that can really help them over time. They're a longer term treatment, so it's usually a couple of years that people are on those therapies for, and they can be quite expensive. So once again, they would need to access those through an allergy specialist. We should be avoiding oral corticosteroids for the treatment of allergic rhinitis, except in the most severe cases, and they would be only accessing that treatment through an allergy specialist as well. And like asthma, we do have treatment plans available. So allergy treatment plans are available for people on the ASCIA website, www.allergy.org.au. So it can be really helpful for people to have an allergy treatment plan, just to remind them of what they should be doing and to help them to know when to increase treatment up. So this is what an allergy treatment, the one on the right, is what the ASCIA allergy treatment plan looks like. And it just gives people instructions about what sprays they're using or what medications they're using, little diagram there and little instructions about the correct way to use the nasal sprays. It's got a little area there about thunderstorm asthma, which is fantastic. And it's got a section at the bottom there about immunotherapy. So they're a great plan, and I encourage you to go onto that website and have a look at it. And the chart on the left there is from the Asthma Handbook, and it's just showing you an example of making that assessment. So looking at the pattern of symptoms, deciding whether they're mild and intermittent and what therapy would then be instigated, reviewing that therapy in a couple of weeks. If it's working, great. If it's not working, what to move to. If it's more moderate to severe allergies and allergic rhinitis, then starting with those intranasal corticosteroids, looking at add-on treatment, once again reviewing controlled and then less well controlled and what to do next. So these resources are readily available for you, and I'd encourage you to have a look at them. I popped this slide on. This is the National Asthma Council allergic rhinitis treatment chart, and this is just showing you some of the more common devices available. There are more now. There's always more. As soon as we print these resources, new medications come available, and there's other ones that need to be added on. But it's just to give you an idea of what the chart looks like. It's available for you to order online from the NAC website, or you can download it and print it up yourselves. Because we're all working from home at the moment, we can't post these out to you in paper copy, which we would normally be able to do. But hopefully, once we get back into the office, whenever that might be, you can, of course, order them and we can send you out the actual poster. Alrighty, so I just wanted to point out that we often forget in our primary care workplaces that we've got specialists, and we've certainly got allergic specialists. So if you're helping someone manage their allergic rhinitis and they're not responding as you think they should, or you've followed those guidelines that we were just chatting about and it's not working terribly well, their symptoms remain quite persistent and severe, it's a really good idea to refer them on to an allergy specialist. Remembering also that if they've got quite poor asthma control, despite regular preventer treatment and adherence to that treatment, it can be their allergic rhinitis that is affecting their asthma control. So that might be another reason to refer them on to a respiratory physician as well. If there's other allergic conditions that we were mentioning, the severe eczema or severe asthma, then that's a good reason to refer. Other food allergies, other complications. So if they've got really chronic sinusitis, or they've lost their sense of smell, persistent ear infections, these types of things might need an ENT specialist. And as I said, if they're contemplating immunotherapy, or if you think they'd really benefit from immunotherapy, then it's a good idea to refer on for a specialist review on that. So that covers my little update on allergic rhinitis. As I said, we will have time for questions at the end, and so please jot down your questions or pop them onto the question manager there, and we'll be able to answer those at the end. Okay, so these are just some definitions of thunderstorm asthma. And I know it sounds very biased, but I do like the National Asthma Council one, which says an unusual cluster of allergic asthma flare-ups, including severe acute asthma, associated with some types of thunderstorms in spring or early summer. And I tend to like that one because it gives us a good description. They're allergic asthma flare-ups, so this is definitely caused by an allergic trigger, can be severe and acute, which has happened in the past, and it's not all thunderstorms. So it says some types of thunderstorms, and I'll go into that as we go along. So a little bit of background history about the thunderstorm asthma events. The one that sticks in all of our memories is that very severe and acute event that happened on the 21st and 22nd of November in Melbourne in 2016, the last one there on the slide. So it stays fresh in our memory for any of us that were working on that day or any of us that are in the field of asthma management on that day, but it wasn't a single event. And this slide I think is really interesting because we've got data going back to 1984 in Melbourne, and you can see there 84, 87, 89, 2003, 2010, 2011, and then 2016, all of them in November. So this is why we start talking about allergies in springtime, thunderstorms in springtime, because it can potentially come our way. And you can see there that they were various times of the day and various severities. But it's worth pointing out that let's just look at the last two, 2011. 2011 occurred overnight, 3:30 till 6:30 a.m. and resulted in 30 extra admissions to ED above and beyond what would normally be expected. 2016 occurred at 6 o'clock in the evening on a very hot and windy day, resulted in 3,500 people to ED. And partly because 3:30 till 6:30 a.m, we hope most people are asleep or not as many people are outside experiencing that thunderstorm, whereas at 6 o'clock at night, many more people were outside. I'll talk about that further, but the data is interesting. It's not the only thunderstorm that event place, of course. So within Australia, there have been other events recorded, Tamworth, Wagga, Newcastle and Canberra, and there's been some incidents recorded internationally as well. So just looking at that event that occurred in November 2016, as I said, it was 6 o'clock at night, and in the 30 hours after that time, these are the numbers of people in Melbourne that presented to hospital emergency departments, an enormous increase, 672% increase from the above 3-year average, and then a massive increase in asthma-related admissions into public hospitals as well. And not forgetting, tragically, that 10 people lost their lives from that event as well. So it's very, very significant. And it's really important that we are prepared for it. You can imagine what an overwhelming effect that had on our hospital departments, on our primary health care and our community providers as well. So what's causing that? It needs to be, as I said, quite a specific set of circumstances or conditions that are available. So it's a high pollen day, which today was a high pollen day, and they have determined, because of the time of year that this happens, that it's mainly the ryegrass pollen that seems to be the culprit, but it could be other things as well. Fungi and dust are common. We need to have what's called a thunderstorm outflow, and my next slide will explain that to you. The pollen normally is a little bit larger. It's about 10 micrograms, and that is normally able to be filtered through the nose. But in the thunderstorm asthma events, the pollen particles are broken down to much smaller particles, and then they're able to be breathed right down into the small airways of the lungs, and then it can affect people that may otherwise not normally be affected. And as I said, it's about the number of people who are exposed at that particular time. So we can't do anything about the high pollen count. We can't do anything about the thunderstorm outflow or the respirable sizes of the pollen. What we can do is be prepared and educate people about their exposure, these people that are at risk. So just talking about the thunderstorm and the type of thunderstorm, and this slide looks at a visual representation of this type of thunderstorm that I'm talking about. So we've got the pollen there, the pollen from the grasses and grains, and it's swept up into, with the wind from the thunderstorm, it's swept up into the clouds in the storm area, which is all very moist up there. Once the moisture and the pollen mix, then the moisture causes the pollen to rupture into those very small particles. Ahead of the front, the wind and that downdraft brings that pollen right down to ground level. That's called the downdraft wind ahead of the rain. And then this outflow is what brings that along and can expose people to these very tiny pollen fragments, and then they breathe it in and can affect them. So I really like this slide to sort of help us understand why it's not all thunderstorms. And the thunderstorm, the Vic Emergency app, thunderstorm app weather warning talks about types of thunderstorms. So that's useful for us to know. Now this slide on GoToWebinar platform doesn't play, but it does show us the larger airways, the larger pollens there. So this is what normal pollen would be. And then down here, this is what pollen would look like when it's actually ruptured. So those really tiny little particles there are what gets swept along in that downdraft and that outflow in those really respirable sizes, and that then affect people, and we can see how easy it is to breathe those in. All right, so as we've been talking about, the people at risk, anyone that's got a known sensitivity to ryegrass pollen is at risk of asthma and thunderstorm asthma, of course. So anyone with allergic rhinitis, because we may not know what they're sensitive to, but springtime allergic rhinitis, we can presume a high proportion of those folk are allergic to grass pollens. These allergic rhinitis sufferers may know they've got asthma, but some of them probably won't know they've got asthma, or may have had asthma many years ago, but don't feel that they have it anymore and are not on any asthma treatment. Anyone with asthma, especially those with poorly controlled asthma or those that are not taking their preventer, are at increased risk of thunderstorm asthma events. And that makes perfect sense. So there's a high exposure to triggers on that day, and if they're not taking their regular preventer, then that can affect them more urgently. Those that have ever had asthma, now this is an interesting group and harder to identify as well. So these are the folk that perhaps had asthma in the past as a child perhaps, and may not have had it for many, many years, but may still have this hyper responsiveness within their airways when certain triggers occur, and because these pollens are now very tiny and can get breathed down into their airways, that's why these people can be affected. So they're a group that are harder to identify, that we want to be thinking about in springtime and thunderstorm season. Then, of course, we're talking about these people, these at-risk groups that are exposed to the open air before and during the thunderstorm in the pollen season. So that's when our weather warnings can be really helpful to us. And anyone that's living in these high-prone pollen count areas. So that's historically southeastern Australia. The South Australia, the lower part of New South Wales and Victoria are the areas that we know these events have occurred in the past. So our general advice and management for people that are at risk is to avoid that outdoor exposure if we know that the pollen count is high and a thunderstorm is predicted. And this is where the technology we've got now is so very helpful for us. So there's AusPollen app, the Aerator app, and the Vic Emergency website. The Melbourne pollen count operates from October through to December. These are available online, and I'd really encourage you to have a look at those. Use apps if that's your thing. If that's not your thing, then that's on the weather forecasts, on the news generally, certainly on the ABC emergency broadcasts that come out. They will certainly talk about thunderstorm warnings on those websites. So Vic Emergency website there you can have a look at as well. Just really useful to help people to be aware if risks are about. If you're in the risk group categories, then the advice is, if possible, to be indoors as much as possible on those high pollen count thunderstorm predicted days. So in the house or in the car, close the windows, turn the aircon onto recirculated air if at all possible. We're trying to reduce the exposure of the pollen and the dust on those days. If people have any signs of asthma, then they should follow their personal asthma action plan. And we know that, as health professionals, we know that, but it is a message that can get lost in the community, and we know that the uptake of written asthma action plans is not that great. But springtime's a wonderful time to be really promoting asthma action plans, encouraging people to understand their plan and know what to do. If they don't have an action plan, then they go to asthma first aid, and I'll talk about that further on in the presentation tonight. Of course, if symptoms are worsening rapidly, then dial 000, as we would encourage everyone. If they're in trouble, they're concerned and panicking, they must dial 000 and tell them that they're having an acute asthma attack, and they'll be advised accordingly what to do. There's a real reluctance in the community to dial 000, and I find this in my normal work in asthma education, or when I'm talking to people about their asthma action plans, they say, oh no, I wouldn't like to call an ambulance. And I say, well, that's actually what the ambulance service is for. If you need them, you need to call them and know how to do that. So how do we manage the risk groups, particularly those with asthma and allergic rhinitis? It's a really great time to be really proactive in our practices. So making sure we're arranging review appointments for these folk. This is the time to do it. Get them in, review their asthma management, review their asthma control, ask them how they're going, assess them for allergic rhinitis, see what they're using for allergic rhinitis, talk to them about their increased risk, remind them that pollen seasons are dangerous for them or might be dangerous for them. Thunderstorm season can pose risks. Have they got a plan in place? You know, what are we doing for them? We manage as per our current guidelines. So that's for allergic rhinitis and asthma, of course. So we'd be looking to the asthma handbook for the current asthma guidelines. And these guidelines now say that preventive therapy is recommended for most people, even those with mild asthma, and that's usually an inhaled corticosteroid therapy. So check that they're taking it, check that they're using their device correctly, and that they're taking it as it's prescribed. They're really important. And remind everyone that they need to be carrying reliever therapy. So depending what their preventive therapy is, that would be either short-acting beta-2 agonist, usually Ventolin or Bricanol, or now for mild asthma, it may be what's called anti-inflammatory reliever, and that would be Symbicort, that they can be using as a reliever therapy if that's their what they're scripted at the moment. So remembering that we need to be proactive with the treatment for allergic rhinitis as well for these at-risk groups. Assessing for allergic rhinitis, as I've said, and start treatment for their allergic rhinitis prior to and throughout the pollen season. And generally that's intranasal corticosteroids for those that have got a diagnosis of allergic rhinitis, and particularly if they've got both conditions, allergic rhinitis and asthma. And then once again, ensure that their action plans are up to date and that they actually understand it. So those with allergic rhinitis and no asthma, we need to remind them that they are at risk of thunderstorm asthma potentially. So we want them to be managing their rhinitis via the guidelines that I've talked about. If we can identify what they're allergic to, that can really help us. But if we can't identify it, then we just need to treat over springtime. So once again, inhale intranasal corticosteroid spray generally, beginning now or earlier than now even, and then throughout the pollen season. If they're people that aren't normally in these high pollen areas or the high risk areas for thunderstorm asthma, but are travelling into the area, for example, then that's another good discussion to have. If they suffer with allergic rhinitis and they're travelling into one of the more risk areas, then it's a good idea for them to make sure they're taking those medications with them. So if they have allergic rhinitis and no asthma, we might talk to these people about recognising asthma symptoms. You know, just a gentle reminder, the common symptoms for asthma: wheezing, chest tightness, shortness of breath or cough. If they experience those on any of these high pollen count thunderstorm events, then they need to know what to do. So they can buy short-acting reliever over the counter. They can buy their Ventolin or Bricanol over the counter, making sure they know how to use it, and providing them with asthma first aid information. Just about being as prepared as we possibly can for our at-risk groups. And those with no seasonal allergic rhinitis and no asthma, then we just need to be reassuring them that their risk is quite low. I know in my practices after the November 2016 event, I was just fully booked for months and months and months, which was wonderful with everyone with their asthma and allergies coming in to talk about it. But I also had people booking into the clinics to see me because they were just, you know, so afraid. They'd been affected by the event. They'd known people that were affected, and, you know, there was a lot of media coverage about what happened and that people died, of course. So we need to reassure people that their risk is quite low, but what they can do is make sure they know about asthma first aid. It's an opportunity for them to understand asthma first aid because they might be able to help someone in their family or in the community and save a life, which would be just excellent. So just a little slide on asthma action plans. As an asthma educator, we always have to talk about asthma action plans. And I really just want to say that they're way more than just a piece of paper. So we've got plans available. There's a large library of action plans on the National Asthma Council website, so please go and have a look. This picture is the NAC plan, but there's many available that work with the practice softwares. And so there's, you know, lots of opportunities to make sure people have a plan. But written asthma action plans improve outcomes by helping people improve their asthma control. So it makes people aware of their symptoms. You're talking about recognising their symptoms. How do they recognise when their asthma is getting worse? That's a discussion to have with them. And then it gives them direction on what to do, how to adjust their medication, what to increase when, how frequently to take it, advice on when to see the doctor, and advice on when to call that ambulance. So they're usually colour-coded there, like this one is: green when they're quite well, when they're fine, what their normal treatment is; orange when things are changing and they should be monitoring; caution, orange for caution, watch, act, do something; and then red, we're in the danger zone now, do this treatment, you need to see a doctor today; and then emergency, dial 000, away we go. Community first aid for asthma is quite different. So this is for sporting clubs, schools, everyone that out there in the community, that this is the treatment that we can provide if we see people have got asthma and we know what to do with it. And you might know this as 4x4x4, and it's called that because it's 4 separate doses of a short-acting reliever, usually Ventolin, via a spacer. So that's 1 puff at a time into the spacer, 1 puff, 4 breaths per puff. Do that 4 times and then wait 4 minutes. Monitoring that person the whole time. Sit them up, keep them calm, stay with them, reassure them. If the symptoms are persisting, we repeat. We give another 4 puffs, 4 breaths per puff. If that's not helping, then we dial 000. Asthma action, beg your pardon. Community first aid does allow for other medications, of course, so it may be Bricanol that they're using, and now it may be Symbicort that we're using. So it's worthwhile making sure that you understand the community first aid. And these posters are available in the from National Asthma Council as well. So how do we prepare for springtime thunderstorm asthma season? We know what we should be doing. So at your clinic, I'd really encourage you to prepare early. Proactively review everyone with asthma, particularly those that you may know are not as well controlled or that have allergic rhinitis or that were affected by previous thunderstorm asthma events. But it's a really good time to just, you know, do your database search, get everyone with asthma reviewed as much as you can. At the moment, that may be that you're doing that through telehealth with COVID. If you can't do that in person, it may be a really opportune time to have a telehealth consultation for those with asthma. Be aware yourselves of the high pollen count and thunderstorm weather forecasts, because you might get more people coming into your practices on those days, and you need to be aware. Make sure that your supply of bronchodilators are in date and that you have some in the clinic that you can use. And you know, if there's a sudden influx of a lot of people, then we need to make sure that we can actually manage that in our primary care services. Have a supply of spaces available. There's a large variety of spaces now, single-use spaces. They can be the light air cardboard ones, or they can be other, you know, there's a large variety of them. So contact your medical suppliers and make sure you've got a good supply of spaces. Have a clinic policy for patients presenting with asthma, and I think this is a really opportune time to be thinking about it. So your frontline medical receptionist staff, make sure they know their triage and understand triaging for those that come in with respiratory symptoms. The practice nurses and GPs know their responsibilities, what medication can be given, your methods of recording that when you're going to call an ambulance. Great opportunity to train all your staff in asthma first aid and have a chart on display. If your clinic doesn't have an asthma educator or a practice nurse that's confident to assist patients with asthma education, then Asthma Australia has a free 1-800 number that you can use there, 1-800 asthma. It's the coach program, and the community can call in and speak to an asthma educator. So that might be something that you can refer your patients for. In your pharmacy, then we always want to make sure that there's an adequate supply of asthma medications as well. So certainly in the November 2016 event, many people presented in the community to pharmacies, and pharmacists were as overwhelmed as other healthcare providers as well. So the reports that came out of that event certainly indicated that at all levels of primary care, we need to be prepared for thunderstorm season. So making sure you've got an adequate supply of asthma medications and adequate supply of spaces. There's a flowchart available on the NAC website for pharmacists that identifies ways of recognising people at risk. So it talks about those that come in to purchase perhaps allergic rhinitis medications over the counter, and then it suggests doing an assessment. Do they have asthma? If they do, what are they taking? Should we be preparing them and educating them, making sure they've got an asthma action plan? So that flowchart's available on the NAC website as well. But this is a good time for all staff, including the pharmacy assistants and the dispensing technicians and pharmacists, to know what to do. So know that it's a conversation to have within that workplace. Training everyone with asthma first aid and have the first aid chart on display, and a great opportunity to know which clinics are open later in the evenings, perhaps, or at night. Where to send people, the nearest hospital, how to help people if you do get an influx of people with thunderstorm asthma, that we would know how to help them. So that's a good idea to do at your pharmacy. So thoughts to consider about thunderstorm asthma. Does your clinic or workplace have an emergency asthma plan policy? And who's responsible for the different aspects of care? Is there a consistent approach to emergency asthma management within the practice or within the pharmacy? Does everyone know where the reliever is kept? There's a lot of information available there in the asthma handbook about helping you to prepare for all of that. But it's a good time to be prepared for springtime. So we just do need to talk a little bit about asthma and COVID, of course, because that's what's ruling our lives at the moment. There's a section in the handbook on COVID under clinical issues as well, so please check there. The advice is that everyone with asthma has a current written asthma action plan, and that can be updated via telehealth if needed. TSANZ and ANZ SRS have just released new spirometry guidelines, so those are available, and spirometry can be performed now, taking precautions. So please refer to the handbook there for looking at the precautions that are required if you are going to be performing spirometry in your practices now. Those with asthma should be advised to continue with their current asthma medications during COVID, especially their inhaled corticosteroids. The data so far has not led us to believe that people with asthma are at any greater risk of acquiring COVID-19, but of course, the symptoms can be confused with COVID. So we need to recommend anyone that comes in with the COVID symptoms gets COVID tested, and people coming in with their asthma symptoms are managed accordingly. Only using oral steroids for severe flare-ups as indicated. An excellent time to remember that we always try to avoid using nebulizers, but at this time, of course, there's a lot of aerosol droplets from nebulizers, so a well-fitting mask and spacer is preferred, and it's not a new message, but a good time to be remembering about that message. Same with the next one, advising not to share any medications or spaces, even between family members. So that's never a recommendation, but we do know that it sometimes happens. But when there's a high risk of infection, then we would not be recommending that, of course. But I think it's an opportune time to just give some thought to how we would actually manage, you know, a thunderstorm asthma emergency during COVID with potentially a lot of people coming into the clinic, and then it's about making sure everyone's really on the ball with their screening, with their triage management, with their PPE availability, all of those types of things. And I'm sure you have thought about this in your workplaces, but tonight's an opportunity to think about that and have a discussion. So that's the end of my presentation tonight. Thank you so much for your attendance and your concentration. These are the resources that I'm recommending there. The handbook, of course, our website, which has got a lot of resources there, the Asthma Australia website with the coach line there, but they also have a lot of really good consumer-based resources that you might like to look at. The Askia website for all the information on allergy and allergic rhinitis. So handing back to see if there's any questions to you, Emma.
Thanks very much, Marg, for your presentation. We appreciate that. There are some questions, so I'll just read them to you for you to answer.
Sure.
What's the role of depot-medrol injection in hay fever?
Depot-medrol injection in hay fever. Well, that's a corticosteroid treatment, so it's not a treatment that I'm familiar with in the primary care settings for hay fever, and I would suggest that it's not the front line of treatment, as I've talked about. The intranasal corticosteroid sprays are working directly with the inflammation there, so they would be the recommended treatment. So I'd perhaps ask that person to check on the Askia website for the allergy flow chart and see where that might fit in, if at all.
Okay, thank you. Someone would like to know the differences for thunderstorm asthma in kids versus adults.
So I'll answer it from the risk perspective. So okay. Once again, I think the message is that we talked about those risk groups, so anyone that's got allergies. So if those children have hay fever, have asthma, they are in a higher allergy group. That anyone that has those allergic propensities can be affected by thunderstorm asthma. But if the question was about the breakdown of whether more adults or more children are affected, I'd have to get back to you on the answer for that one.
Yeah, they've said both. So,
okay.
Yeah.
So the breakdown data for how many children were affected in the previous events would be in that Victorian report, but I don't know that from the top of my head. I'm very sorry.
That's okay. Thanks, Marg. What is the best management for people that have allergies all year round rather than seasonal allergies?
Yeah, well, that's a great question too. And I guess you would be coming back to thinking about that flow chart that I showed you that's available in that asthma handbook. So it's about assessing whether they're mildly affected all year round or moderately to severely affected, and then instigating that treatment. So looking at the intranasal corticosteroid sprays and then moving down from there. If they don't work, then you might add in some concurrent antihistamine treatment. And if it's really not responding well to treatment, then they might be a good person to refer on to an allergy specialist to try and identify what it actually is that's affecting them all year round. Because I imagine, I mean, I get springtime allergies and they drive me nuts, but I know it's only for a few months of the year. I can imagine people that have those symptoms all year round really would benefit from some solid help with that.
That sounds exactly right. I can agree with that. What are the options for managing hay fever in people who do not want to use INCS nasal spray?
Okay, so look, one of my suggestions about that would be that it's that word corticosteroids. So we talk about corticosteroids and people think of steroids and oral steroids. And in any situation, so for the asthma medications, the inhaled steroids that we use for asthma and the intranasal steroid sprays we use for allergic rhinitis, these doses are in micrograms. They're tiny, tiny doses compared to an oral tablet, which could be, you know, a 5, 10, 25, or even a 50 milligram tablet. So people have memories of all of those terrible side effects of oral steroids. But I would first chat to people, make sure they understand that these are nasal steroid sprays that are in very tiny doses but are very effective because they're working right there on the inflamed nasal passages. But if they really don't want to take them, or they have side effects to them and they can't take them, then it's going back to those other treatments that I talked about. So things like the antihistamine sprays, they won't treat the inflammation, but they will help with the symptoms. Even the saline sprays don't treat the inflammation, but may help to wash the area and reduce symptoms for people. Or they may feel more comfortable to take an oral antihistamine tablet rather than using a nasal spray. And sometimes for kids, we need to think about that, because very difficult for little kids to actually tolerate a nasal spray. It just doesn't really work for them, and you might need to be using oral antihistamines, particularly for kids.
Great, thank you. All right, we have one more here. Do you think that face masks that all Victorians are currently wearing may assist somewhat during high pollen count times?
Well, that's a really good question. The information that I understand about face masks is that it would only be the surgical quality, so those N95 type masks, that would probably get rid of the really small particles. The other masks that we're using, the cloth masks and those types, may reduce some of the larger pollen particles. I don't have the actual data on that, I'm really sorry. But they're compulsory at the moment. We have to wear them regardless for COVID. They might help some people. They make other people feel a bit claustrophobic and feel like they can't breathe. So it's a difficult one. We have to wear them regardless. Yeah.
All right, well, that's it for questions tonight. So I think we will finish up. So thanks very much, Marg, again, for your presentation. Thanks, everyone, for attending. And in terms of Murray PHN webinars, you can find upcoming ones on the education page on our website. So thanks again, and good night from us.
Good night.